I am with the Centers for Disease Control and Prevention, and Hanta is a viral special pathogens branch, which among other viruses has worked on hantavirus pretty much since 1993. This is my own first time on Navajo Nation, so it's a pleasure and privilege to be here with you all. And I'll be presenting some slides, and then I have a number of terrific colleagues that will present after me, so I'm going to try to keep it short. I'm also presenting on behalf of my supervisor, Mary Choi, who couldn't be here but would have loved to be. She had other commitments, but she's been involved with Dr. Engel and Tara on the development of the 5-point screening for use on the Navajo Nation. So I'm really here kind of in a pinch-hitting role and to just explain a lot of the work that's been done by other folks, and particularly both here in Navajo Nation and University of New Mexico and other places. So it'd be great to talk, and particularly after that great session with Sheldon. So next slide, please. So I'm just going to quickly give you already heard a very in-depth patient presentation, so I'm going to give a quick clinical review of just some of the points on hantavirus and explaining why this 5-point screening is useful, and then we'll briefly talk about the use of it here in the Four Corners region. Next slide. Next slide. So this is basically what putting all Hantavirus Pulmonary Syndrome in kind of in one slide looks like. So when a person's exposed to hantavirus, there's actually about a 1 to 8 week period during which the virus is just kind of quietly incubating. So perhaps Sheldon may have actually been exposed anywhere from 1 to 8 weeks before he actually started feeling sick. And that's just the amount of time it takes for the virus to replicate and start to cause trouble. And that first stage of when people feel ill is what we call the febrile prodrome. And that's basically just about a 3 to 6 day period. I think he said it was something like maybe 7 days, 8 days, where he told you all the symptoms of maybe some fevers, aches and pains, not feeling quite right, thinking it's the cold, the flu, something's not right, but probably just something else. So it really won't necessarily feel like something unique, but over time it will get more severe. And that's the stage where we often will see patients first come into care, and the challenge and the whole point of this 5-point screen is trying to separate those patients out from the way more patients that come in with those symptoms that usually don't have hantavirus, because it is still a fairly rare disease. And that's really the challenge that this screen tries to address. And you've already heard a lot about the rest of the disease, so after that period of time, it's pretty quick and how quickly patients will get worse, and they go into what we call the cardiopulmonary stage, where the respiratory failure, et cetera, is very profound. And roughly 30 to 40% of patients will die, and that's during that phase, which is very, very severe. Actually, after that phase, we go into the diuretic phase, where a lot of fluid kind of comes out. And then convalescence, there's so many different things, and every story is unique as to what people go through, but obviously it can be months to years in terms of getting back to baseline or a new baseline. Next slide, please. This is that same idea in just a visual form. I think I'll skip through just for the sake of time, if you could pass through. So this is really the challenge of how do we diagnose someone with Hantavirus Pulmonary Syndrome, and there's a lot of challenges. The first challenge is that it's rare. Even here, it's still way more common to get the flu. It's still way more common just to get the cold, and certainly, it's not something that most doctors, most nurses see all the time. It's not that common. Most people aren't always asked about, did you have contact with rodents in the last week or two? It's just not the first thing that you typically have a conversation with when you go to see the doctor and tell them you're not feeling well. They don't say, hey, before we get started, did you have any, did you see any mouse traps or anything? It'd be kind of odd. Why would you ask me that randomly? So you have to really think about it, and that's a challenge. And many clinicians, doctors just haven't seen a case. It's just very rare. There aren't many of them. The other challenge is that, like we've talked about, it looks a lot like other illnesses, especially early on. So it looks just like the flu. We heard about how it feels like a pneumonia. There's not a whole lot to distinguish it. One of the things that is that is a little bit different is that it can occur in the spring and summer months like we saw yesterday. So it's a little bit odd to get the flu, in June. It's just not really flu season, so that does make it a little bit more odd, but you can see it year-round. So the bottom line is that in some way we have to have what we call a high level of suspicion or a higher level of suspicion in the appropriate context. And that's one of the things we try to do with this screen. Next slide. So there are tests for hantavirus. We can look for it directly. There is a test that will look for antibodies to hantavirus. And so by the time patients get sick, if you do a test for that, IgM, which is an antibody that's formed early on by a patient who has hantavirus, or IgG, which is formed later, we can find it. And those tests are available, and they're available both at state labs and also at the CDC, and there's commercial assays which we'll hear about as well. But the problem there is that it's not a quick test. Just running the test takes at least 6 hours, maybe longer, and then getting the test to the place where the test can be run takes even more time. And we heard about how quickly patients can deteriorate with hantavirus. So it's not really the ideal way to make a decision as to is this hantavirus or not. Next slide. And so what can make a difference in terms of treating patients with hantavirus? And we heard again Sheldon talk about ECMO, and ECMO really is the only proven intervention that we have medically for hantavirus. We do not, unfortunately, have a direct treatment for the virus. This is really the key thing that we have, and it's a very aggressive medical intervention, but it's been shown to work. And so, given that that's the case, our goal is to have as rapid referral as possible of patients who might have hantavirus to facilities such as the University of New Mexico and Albuquerque, where that procedure can be done, because it can't be done everywhere, and that's the closest place. And so to do that, we need to figure out, okay, well, who has hantavirus, and we need to figure that out quickly so that we can get them over to where they can get that care if they should need it. Not everyone needs it, of course, but many people will. So next slide. And so in addition to ECMO, there's blood pressure medications, supplemental oxygen, a whole host of other medications if needed. But ECMO is really the key one, and I'll just kind of cut through to the next slide for sake of time here. This is a real basic diagram of ECMO, but just so you can all see, the blood is taken out of the venous side of the body where there's not as much oxygen. It's put through a pump, and it's actually oxygenated, and then it's put back into the body, into the arterial side. And that's basically to support the body while both the heart and the lungs are not doing well. So a lot of the work looking at ECMO for hantavirus was done at the University of New Mexico. And one of the studies took a look at about 50 patients that had come in that were very, very sick with hantavirus, that were expected essentially to pass away. And they looked at how people did when ECMO was started fairly late versus how people did when they got to the hospital and they got ECMO queued up, so they inserted the catheter, kind of got everything ready, and then started it if they needed. And they found that patients that came in that actually had ECMO kind of system up and running a little bit earlier, that had the access to ECMO should they need it, survived quite a bit more. So 80% survived in that group compared to 54% in the group that got it, on the later end. So what we've seen is that the earlier access to ECMO, the better patients do. Next slide. So the 5-point screen. So the 5-point screen is based on a few things that we see in hantavirus that does not happen in other infections, and that's actually what makes it special and useful. This is just taken from one publication of what happened to patients' blood tests with hantavirus. And so, number one, the platelets decrease. So if you look at the black dots there, the platelets, which do a lot of clotting functions in the body, they start dropping off pretty quickly on day 3, day 4, day 5 of illness. And those are days, by the way, during which patients are not going to have a lot of that shortness of breath and all the really bad pulmonary symptoms that we heard about. This is still really early on, where you just kind of feel like you're run down. Again, like Sheldon was saying, the flu, muscle aches, maybe I have a cold. If you just have a cold, your platelets should not be tanking. So that's special and that's different. your white blood cells going up. That can be seen in a lot of infections, but that is something that we see as well, and that's shown by the triangles there. And then this one special kind of cell called immunoblast, which I'll let Dr. Engel talk about more, but it's an early type of one type of blood cell, and I'll show you a few photos in a minute, but that includes it as well. And then also the hematocrit, which is kind of a concentration of your red blood cells that increase. So kind of taken together, if one patient's coming in with what maybe feels like a cold, but these kind of wacky findings are going on, it speaks to the idea that maybe we should be considering hantavirus early on. Next slide. And so that's what the 5-point screen is. These are the 5 points, and they're just based on what I showed you in the prior slide. So low platelets, high white blood cells, more immunoblasts, or these kind of early white cells that you don't typically see in all kinds of infections. I'll show you a photo in a minute. And then neutrophils, which are your one type of white blood cells that are involved in certain types of infections. They don't have what we call toxic changes, and again, I'll defer that to some photos in a minute, but usually you see those in a lot of infections, and weirdly enough in hantavirus you don't see that, so that's something to pick up as well. And then increased hematocrit. Next slide. So this is just a few quick images. That's what a normal lymphocyte looks like. That blue one in the middle, the ones around the red ones, those are your red blood cells. And then next slide. These are immunoblasts. So these are like what lymphocytes are before they become lymphocytes. So these are kind of earlier cells. And you can see they have a pretty distinct appearance. What I couldn't find is that they're about 3 times bigger than this one here. So the size is really dramatically different. And they have kind of that stippling there in the nucleus and a more blue color there in the cytoplasm. So they look a little bit different. Next slide. And we also get what we call kind of a left shift. So you see earlier cells in the neutrophil line. So not as mature. And again, I'll leave this more to Dr. Engel. Next slide. And this actually is taken from a patient with hantavirus. So thrombocytopenia, you don't see basically don't see any platelets at all. That just means low platelets or no platelets. A lot more red cells, kind of per volume, and again a left shift. Next slide. Okay, so the 5-point screen's been studied at the University of Mexico, and it was originally developed once clinicians started realizing that this is unique and potentially useful. And so they looked at these 5 criteria and did some studies, and they found that any patients that have about 4 out of the 5 of those, so they meet 4 out of those 5 boxes, the test is very good at saying this is hantavirus and probably only hantavirus. So 96% sensitive and 99% specific, which is an enviable feature of any lab test. That means that it's this and only this. Another study that was done that looked back at 10 years of cases in the University of Mexico, so about 158 patients. They found those numbers maybe were a little bit inflated, but still very good, 89% sensitivity, 93% specific. And of the 31 cases that met 4 out of the 5 criteria and received treatment, including ECMO if needed, about 87% survived, which is a very good number. Next slide. This just shows the sensitivity, specificity, positive predictive value, negative predictive value of each of those 5 tests. So if you just look on the sensitivity alone, thrombocytopenia is actually pretty sensitive, but some of the others aren't. And then hemoconcentration is really specific, but some of the others aren't. And this is just basically to show that you need to have all these kind of put together and have trained laboratorians that can evaluate these together in context and look at them all together. Not each of these on its own is going to necessarily do the trick, though it might be a clue. Next slide. And this last one here just shows the same study I was telling you about, but they looked at 10 years of cases from 2001 to 2011, and you can see the total number of cases in that top blue line, so per year. That's just the total number. And then in that green triangle line, it shows you how many had a positive result by the Hantavirus screen, the 5-point screen, compared to a positive IgM or a positive laboratory result for hantavirus. So that's a definitive hantavirus positive result. And you can see that they're basically the same, that the green and that orange line run together. So they're basically it's as good a test essentially as the hantavirus specific test. That really makes it a very useful test. And the same thing for a negative, so it's very sensitive and very specific. Next slide. So there's some limitations. It's not a perfect test. No tests are perfect. There are some false positives that they've seen. There's some false negatives. And one of the things that's really key is that sometimes patients come in and maybe they only have low platelets, but not a lot of the other features, or maybe they have 2 out of the 5 criteria. And that's where you can't really substitute for some clinical judgment and some decision making. So what the authors recommend, and what we've also recommended, is waiting some time, not very long, but maybe 8 hours, 12 hours, if somebody's kind of right on that cusp, and see what happens to some of these numbers over time, because the change is pretty dramatic. You should see the platelets start really dropping. And so looking at these over time, we'll start saying, okay, well, if a person came in with 2 out of the 5 positive, and now they have 4 out of 5 positive, a little bit later in the day or tomorrow, that changes things. And these other points just mention that there's help at UNM. They have a lot of experience with this, and they have a call line to help make these decisions and determine, if a person looks like they meet the criteria and could use an airlift to University of New Mexico, even if it ends up being the flu, on the other hand, if it was hantavirus, you could save their life. So that's something to discuss with them. Next slide. And I'll kind of transfer it over here, but this is something that Tara's going to talk about more. We've been working closely. Sorry, Dr. Who's going to talk about more? Okay, you're next. Okay. Anyway, more capable folks will talk about than me, but we've had a number of workshops and trainings here on Navajo Nation to help laboratorians in the facilities here be more comfortable with this, with what I just described. So comfortable with looking at slides, identifying these changes, and trying to basically find early cases of hantavirus, or be comfortable knowing what that looks like, so they can initiate referrals sooner. And the goal there is really hopefully that so trying to catch that disease in a patient earlier. Maybe in Sheldon's case, if it was something that could have been seen earlier, perhaps in Chinle, if that had been something that's noticed, then maybe it could have been referred earlier, and so on and so forth. You can never look into a crystal ball, but it's something that we hope could be useful for more patients moving forward. So I'll let you guys talk more about that.
I'm going to be talking about the rationale behind and the development of the 5-part screen. I'll be skipping over some other slides which drill down into some of the details, technical details about the 5-part screen. And if you're interested in learning a little more about that, we're going to have a breakout session later on, and we'll talk more about that. Next slide, please. Next slide. Okay. What I first want to go over is the challenges and why we need to screen. And we already got some of the reasons from our first 2 speakers today. But one of the issues is that as we saw that patients with the pulmonary syndrome can have a very rapid progression. And so we need some kind of way to detect there's a need for a prompt recognition and referral of severe cases to a facility where advanced intensive care services are available, such as ECMO. We also need something that, since initial presentation of these patients is very similar to influenza or other respiratory illnesses, so we need to have some kind of test that has specificity that can distinguish patients who are developing the pulmonary syndrome from other viral and flu-like illnesses. We need a test that will alert providers to the possibility of hantavirus infection. Some of the challenges we have here is that a lot of the emergency departments are staffed by contract workers that were trained and might be practiced primarily outside of the region. So if someone comes with a flu-like illness, they think the patient may have flu, and they don't think about hantavirus. So we need some kind of process that would help providers that may be not so familiar with this scenario to help alert them to the possibility of hantavirus. And as was mentioned before, there is no rapid serologic test And from what I understand, there's nothing that's going to be coming down anytime soon. So, and from a practical standpoint, the closest laboratory to this region that can actually perform the serology test is in Albuquerque, and it takes 12 to 24 hours to perform this test, including the transport time to the laboratory. So, and as you saw, in 24 hours, a person can go from mild respiratory symptoms to severe respiratory compromise. And so, next slide. So this really put us into a position where to really identify these patients, when they first present, they don't go to Albuquerque, they present at their local healthcare facilities with these symptoms. And so we need a rapid screening test that can be performed in rural areas where these patients first show up for care. And the other practical considerations is we need a test that can be performed with routinely available laboratory equipment, can be performed by non-specialized laboratory technical staff. We need a test that's not so complicated that it's feasible to train staff on all shifts and to maintain competency to do the test. And we also have considerations. We don't want it to be so labor intensive that it will adversely affect other staff tests that the laboratory is obligated to perform. And we need a test that provides reliable information that actually supports clinical decision making. Is this patient likely to have Hantavirus Pulmonary Syndrome? And that generates orders for emergency air transport. And so that's a difficult decision, and so we need to have a test that can support that decision. Next slide. This is the development of, these are researchers at University of New Mexico that, from the very beginning of the first cases that showed up in 1993, most of these patients were transferred to University of Mexico Hospital, so they had a lot of experience and a lot of data on these patients that they had managed over the years. So actually in 2001, these researchers looked at trying to find some kind of, looking at the laboratory data, and was there distinguishing features of hantavirus infections that could be used to develop a rapid test. Next slide. And the purpose of their study was to identify a rapid method for presumptive diagnosis of the pulmonary syndrome using a peripheral blood counts and smear morphology review. And of course, that's a very common test, and most of these patients had multiple CBCs and hematology studies. So this was a practical, they had a lot of data on that. And they did quite an elegant study in that they took 52 cases, well-documented cases that they had hantavirus patients with the pulmonary syndrome, and then compared them to 128 control subjects who were seronegative for hantavirus but clinically mimicked the pulmonary syndrome. And they found, and looking at the hematology results from those two groups, they found an aggregate of 5 peripheral blood findings, which had the sensitivity and specificity to allow for a presumptive diagnosis of pulmonary syndrome. Next slide. And at UNMH, they implemented this rapid screening tool for the triage of patients with suspected pulmonary syndrome. And since 2001, this 5-part screen is part of the management or evaluation of patients with the syndrome. They found that in 4 out of 5 criteria were positive of the 5-point screen, has a sensitivity of 96% and a specificity of 99%, and missed no patients requiring intensive care. The other observation was that thrombocytopenia is a very early indicator of infection in all the patients that had positive serologies, the 5 criteria, all of them had thrombocytopenia. So that's a very early indicator, good early indicator of evolving pulmonary syndrome. And they proposed that the scoring system be used to guide treatment and patient transport decisions until a more rapid, specific serologic test became available. So this was proposed in 2001, and since that time we haven't gotten that rapid serology test. But hopefully, sometime in the future we can. But in the meantime, this is a specific, rapid, specific tool that we can use and can be performed by any laboratory in the endemic area. Next slide. And this is the five factors that were already discussed. And these are all relatively easy determinations with training to be able to assess for these five particular points. Next slide. And this is another very important point, is that the 5 variables used in the scoring system individually can be positive in other clinical conditions. Scoring for all 5 factors and using a cutoff of 4 or 5 out of 5 increases the specificity for Hantavirus pulmonary syndrome. And another point to emphasize is that if you have this, if you are able to do this screen, you can offer it as a serial test. So if someone has a borderline picture, or maybe you're catching someone early on, because of the rapid progression, and they have a borderline score, you can 8 hours later, 8 or 12 hours later, do another study. If it's some other condition, it probably won't progress, but if it's Hantavirus pulmonary syndrome, then it should, the score should increase and progress with time. So serial studies is a very important tool to be able to offer. And we'll skip through next slide, because we'll talk about these later on. Keep on going. Keep on going. So this is the four out of five criterion. Based on the UNIH experience, the positive predictive value of 90% in the cases that fulfill 4 out of 5 criteria, and greater 90% of the cases meeting 5 out of 5 criteria. When the patient has other clinical features suggestive of Hantavirus pulmonary syndrome. And this is another important case, a point is, even if you have the 5-point screen available, always, if you suspect Hantavirus, always collect a serum specimen for serologic tests. Don't use the serology for immediate patient decisions, but it's very important for case follow-up, and also notify your local health departments and epidemiology groups, because then they can do follow-up studies, environmental assessments, and mitigate any factors or exposures potentially to other people in the community or household. Oh, skip this one, that one. And I'll just talk about a few of the limitations related to this screening. In the UNM study, there was a high pretest probability of the pulmonary syndrome. Essentially, the patients they see that end up at UNM are ones where they've been flown in, they already have a high suspicion of the pulmonary syndrome. So, so the estimates of the positive predictive value, may be different if you're talking about assessment in a community. where you may have patients with other underlying clinical conditions that may cause an elevated score due to other conditions other than hantavirus. And the other point to make is that unless you're in an endemic region where this hantavirus is a possibility, it would not be practical to do this screen in other parts of the country where hantavirus is even rarer than you see it here. So so we're not advocating that every rural emergency room across the country adopt this testing. It's particularly relevant for the Four Corners region. And then the other question will be too, because of this experience with UNM versus experience out in the community, is will the positive predictive value be as high in a community setting where patients may be seeking care at an earlier stage of hantavirus infection, or maybe have other pre-existing conditions that could cause a positive score? And a couple of common conditions would be cirrhosis of the liver, which can cause thrombocytopenia, and chronic obstructive pulmonary disease, which tends to elevate the hemoglobin hematocrit. And those are two of the main criteria of the 5-part screen. But I think with some probing of the history and looking at previous lab results and just being aware that patients may have some other chronic conditions that may affect the score, if that's all taken into consideration before all the full clinical picture needs to be taken into consideration before you just look at, oh, this person has a score of 5, they must have hantavirus. You have to also look at the other confounding clinical factors. The other, next slide. The original paper, and still currently at UNM, the hantavirus scoring is done by specialists in hematology, hematopathologists. And even in their paper, they had a question: would this would you be able to have non-specialized technologists in a hospital or clinic laboratory? Would they be able to have consistency in their scoring, and would this be able to be rolled out to other laboratory providers? And Tara will explain a little more about our implementation of this test at Sohoto Medical Center. But the experience there was that both 2-year and 4-year degree technologists at all shifts, and with varying years of work experience, can perform these screens accurately and consistently after appropriate trainings. And next slide. One of the concerns we had, though, was that this hantavirus screen will not be ordered when it's needed, and this has to do with awareness of the clinical staff as far as thinking about hantavirus. So if they don't order the test, and then then the patient won't benefit from the test. And so, as a result of that concern, and because thrombocytopenia is an early and consistent indicator of Hantavirus Pulmonary Syndrome, we developed a reflex where if any patient that presented to the emergency department or urgent care that had thrombocytopenia, we reflexed a hantavirus screen. And Tara will explain, but that being able to do that, we were able to identify cases from the laboratory that the clinicians didn't even think about ordering that test. So the laboratory actually discovered these cases when it wasn't initially considered in the evaluation of the patient in the emergency department. Next slide. The other limitations is that you have to realize is that the scoring system is a screen. It's not a definitive test. It does have a high predictive value, but you need to have other supporting clinical, it's a presumptive diagnosis, so you need to have other supporting clinical and history factors to take into consideration. And also, as I mentioned before, be aware of any chronic conditions that may show chronic thrombocytopenia or chronic elevated hemoglobin hematocrit, among others. Needs to be taken all together. And the other problem is it's not a test for exposure to hantavirus. The patient has to be symptomatic. This should not be performed on patients that are asymptomatic who may have just gone and saw some mouse drop-ins and wondering if they could get hantavirus. So it's not a test for exposure. And again, I want to emphasize you need to collect a serum sample for confirmation. Last slide. Summary. Currently, the Hantavirus five-part peripheral blood score is the only rapid screening test for patients who may be developing the pulmonary syndrome. Implementation of this test in clinical labs in endemic areas is feasible. No specialized equipment or staffing is needed. Consider offering the test both as provider-ordered as well as a reflex for thrombocytopenia in patients presenting into the ED or urgent care. For case follow-up, contact your state or local health departments and epidemiology groups in order to and be sure you collect a specimen for IgG and IgM testing for hantavirus. And again, I wanted to emphasize the value of the call number. It's a man 24/7. If you have a case even early on, you need information about management and care and management of patients with and diagnosis of patients with hantavirus. Call that physician access line at UNM, and you'll be able any time to get access to a physician who has experience in managing patients with Hantavirus Pulmonary Syndrome. Thank you.
Good morning. My name is Tara Oliver. Kiani Nishlit, Nizani Bashichin, Sotni Dashache, Dashanelin. I'm from St. Michael's, Arizona, and I've been working at the Tsaile Medical Center Laboratory for the past 7 years. I entered when I was a medical lab technician, and then I became a medical technologist where I did a lot of training. I worked mostly in hematology, coagulation, and blood banking. I did a ton of training for employees and students, and so I just naturally fell into this when it started at our hospital. So right now, we're just going to I'm going to quickly go over, I guess, our experience in implementing this 5-point screening. So, next slide. Okay, so we started our screening process May 10th, 2016. At the time, it was just for our hospital. We wrote a procedure for it. We started setting up how we were going to do the screening. Then we talked about who we were going to train. So we ended up training everyone because we wanted everyone in the laboratory to be able to perform this test. It didn't have to be, a lead technician or lead in the department. We wanted all of our staff to be able to do this. Our laboratory is open 24/7, so we also needed, our night staff to know how to run this test. So we trained everybody. In the beginning, it was just a verbal request from the provider. And then we also have lab reflex. So lab reflex is when the lab recognizes certain flags from test results, then they will initiate the test. They don't wait for a provider to put in an order, or they don't wait for the provider or doctor to say, hey, maybe you should run this screen. So a lab reflex, lab will recognize the flags and then just do the test on their own. So right now our lab is set up to do the 5-point screen on any platelets that fall below 120. Usually that's when a patient becomes thrombocytopenic. And then later on, we turned it into an orderable test on RPMS. So if some of you hospital people know what RPMS is, it's now an orderable test, so we don't have to work if the patient has symptoms. If they're coming in with flu-like, they're achy, they're short of breath, then it'll work. But if they come in and just, they're fine, and then they say, oh, I saw mouse droppings outside my house, can you run the test on me? Sure, we can run the test, it's just not gonna really give us anything. Like, you'll probably be a 1, and then that'll be it. Also, we had to train our staff how to recognize immunoblasts and plasma cells, which is, again, it's rare to see these type of cells. So in our laboratory, we do a lot of practices with someone whose score is a 1, someone who's intermediate, and someone who's like a full-blown 4 or 5. Plus we do annual competencies, so we make sure that our laboratorians stay used to the idea of identifying these cells and these 5 criteria. And then in the beginning, like I said, it was just a verbal request. So like the provider or the doctor from ER would say, can you run this hantavirus screen on our patients? So they would just call us. So once they called us, we'd run the test. Then we had to go hand deliver the results to the providers, and sometimes they would, leave for the day, or if it was ordered in the clinic, they would go on lunch, or they would be done for the day. So it was kind of hard for us to run those hand results to them, and so then eventually it became like an online test that you could order, and it would just go straight to the patient chart with interpretations of the score. Okay, next slide. So our outcomes is that our entire staff is trained to perform these screens. There was no interruptions in the turnaround times. And let's see. And like I said, lab has become the first responder when these flags are recognized. So we don't wait for a provider to, maybe, like Dr. Engels was saying, some of these providers, they're not trained in this area, they're not trained to recognize, to think of like, hey, maybe this patient might have hantavirus, So, but we all live here, we all work here, so we're trying to get the lab to kind of recognize certain flags on the results, and they can think of like, oh, maybe this patient has hantavirus. Let's just do the screen. But it's not going to cost any more. It's not going to cost time to do the screen. But for us, I've seen it. When we first started this, we saw a lot of patients come in with the symptoms, and we were really excited at first. But then we really started recognizing that a lot of these patients were showing those symptoms that they talked about. So I feel like laboratory has been like the first flag that goes off, and we just I don't know. It's like it helps our patient get immediate treatment afterwards, and it's good to know that out of all of the 9s that scored really, really high, only 1 had passed, and all of them lived. So it's really touching to hear. Sorry. It was really touching to hear Sheldon talk, because he was one of our patients that I had tested, and it was really touching to hear his story, because like we don't get to meet our patients. We're always in the lab, and his name is like forever burned in my mind. All of these patients that we come across, and so to see him tell his story was like, oh my god. Okay, so Donna Tucker is my manager. She's going to quickly go over community outreach. Okay, thanks.
Good morning. My name is Donna Tucker. I've been with the Indian Health Service for quite some time. We moved out here, my husband and I, in 1988. My husband's from the Shanto area. And I worked with Tube City for about 8 years, and then I moved to Fort Defiance to work there. We relocated. and have been with Fort Defiance ever since through the transition from Indian Health Service to 638 facility. And in that transition, my goal was to really, I worked as a bench tech for many years. I've been in the field for over 30, and was able to gain the opportunity to become a laboratory manager. And one of the things that I wanted to focus on was to really push the laboratory to a state where we could really help our community and bring in new development and really be an icon and a model for our community. And in 2016, the CDC came to TMC and learned about our Hantavirus 5-point screening. So we had already been doing this for about a couple of years, and our team had implemented all the tools and the procedures, and it's not really easy to try to develop a system that can be standardized and trainable with your staff, because your staff, they all have minds of their own, so that was really challenging. But we developed a standardized form, and Tara and Cheryl developed the actual procedure, step by step, what to do. And we had already been doing it for a couple of years, and the CDC came out and did an in-service for the providers on proper, well, just knowledge about the hantavirus, because we do get a lot of contractors and turnover, and was very interested in how we had rolled out this 5-part screen. And in 2017 and 2018, with the CDC support, we got workshops going, because throughout history, we're just a laboratory out here on the Indian reservation, and trying to implement something across the board and say, hey, you know, this is really could benefit the community, and really identify patients early. It was a really struggle trying to put on a workshop, but then when the CDC came in, their expertise and their support, we were able to put something together. And this is a flyer of our first workshop in August at, well, here in Tsaile College. But I think this wasn't the first one. This was like the third or fourth one. Okay. Next slide. And here's some pictures of them. We were able to train over the event over 60 laboratorians. And this is a picture of here at Tsaile College that we provided. And so we had laboratorians come from all over IHS and also public health services out of Arizona and New Mexico. So with this, it's really cool how this test is so small, but it's really a lifesaver. And like Tara was sharing with you, the impact it has on our patients and the survival rate is just really great. And so if there's any organization that is interested in implementing this in their laboratories, we'd be more than willing to go out and share the tools and the forms that we used and the procedure, and help develop this within your laboratory and train your staff so that it can be useful for everyone across this whole area. So our contact information is up there. But also there's one really exciting thing that has occurred from this whole event is the CDC Museum is putting on a exhibit in Atlanta at their museum, and Hantavirus is one of their exhibits that they're going to put together, and it's going to display in September. And there's going to be items that are utilized from the initial exposure and cases in the 90s, as well as our current development on the 5-point screen. So our laboratory and the teams are really excited that they're actually going to get, I think our group photo is going to be in the exhibit, so we're really excited about the whole thing. So it's a little development of the 5-point screen is small, but it's big for our community and for our facilities to be recognized for this. That concludes the presentation on